Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Welcome to a special episode of Talking Head Pain. In this three-part miniseries, we explore migraine from the healthcare professional's perspective. I'm Erik Stone, Director of Data, Learning, and Evaluation at GHLF. I'm also a migraine patient and an advocate, and I'll be your host for this episode. This series is a part of our UP-END Migraine project, designed to help healthcare providers, especially those in primary care and emergency care settings, better understand migraine prevention, diagnosis, treatment, and management. In this second episode, we're diving into preventive migraine treatment, when and why to start it, how to prevent medication-overuse headache, and the latest advancements in migraine prevention. Joining us today is Dr. Nina Riggins, a neurologist and headache specialist who has dedicated her career to helping patients manage migraine more effectively. She's also deeply involved in cutting-edge research, including neuromodulation and CGRP antibody treatments. Dr. Riggins, thank you for being here. Before we get into today's discussion, can you introduce yourself and tell us a little bit about your background?
Thank you so much for having me. I am Dr. Nina Riggins, and I am headache specialist and neurologist. I am at the Headache Center of Excellence in Palo Alto, California. I am also playing multiple roles, but all devoted to the patients and profession to help the patients. With American Academy of Neurology, I am a vice chair for Headache and Facial Pain section. For American Headache Society, I am co-chairing First Contact Headache and Primary Care program that helps to develop information and provide information from headache specialists to all other specialties. And I'm also chair of Women's Health Special Interest section with American Headache Society, which develops all so needed materials, how to treat, for example, during pregnancy, people with migraine, or during breastfeeding, or during any journey of women with migraine throughout the life. I'm also serving as one of the editors for Cephalalgia and Cephalalgia Report social media editors with International Headache Society. I love my work with Women in Neurology group, where I am director of WNJ education in CMEs. So I'm very thrilled to be here, and thank you.
Yeah, thank you so much, Dr. Riggins. It sounds like you bring a lot of really great, diverse experience to this interview. And I'm curious, in your work with other providers, what are some of the biggest misconceptions about migraine prevention that you think other providers have?
It's big variety, actually. That's a great question. So one of the edges of the spectrum is sometimes people think that migraine is just a headache and easy to treat. And it's not that straightforward in many times. And people travel a long way to arrive at the right diagnosis and treatment because of how migraine can present itself. And migraine, of course, is not just a headache. And I know it's been one of the big themes for many patients' advocacy organizations. I am on the board of Miles for Migraine, and I love my work in advocacy. And this is one of big things that we want to communicate, that migraine is genetic neurologic disease. It's not just a headache. And we educate about different symptoms which can come with that. Starting from changes in vision, how a person can speak, and, for example, gastrointestinal symptoms. Can stomach ache, nausea come as one of the things with migraine? I know in the past we were thrilled to reveal that sometimes person, for example, can crave chocolate as part of first symptoms even before pain when migraine attack starts. And this person would think that chocolate was something that triggered migraine attack. And we're happy to give something back. So for people without issues with diabetes and so on, when other things address, little bit of chocolate was okay.
I definitely relate to this difficulty in communicating migraine symptoms. And I know from the patient side, that's a big challenge, just using the right words to describe our symptoms in a way that a doctor can even recognize it as migraine. And I know that as a patient, I carried that belief that it was just a headache, which I've since learned is wrong. And I now know how exactly to describe my symptoms in the best way possible. But from the provider side, I mean, what do you think are some of the barriers that they're having to learning about migraine in general, migraine prevention, how it's diagnosed? Why do you think it's so difficult to get past this barrier of migraine is just a headache?
There's no exact uniform approach to that. Maybe because of variety of symptoms, but also of some stigma, because migraine is invisible disease. And sometimes from multiple people we hear, oh, for example, I did not know that kids could have migraine. And 1 in 11 kids have migraine. So from this, we come into our work on making education more available. And I really appreciate your work here to educate and raise awareness about migraine. It's second disease according to multiple classification and publication in disability worldwide. And more than 1 billion people have migraine. So we need to make it more unified in the way how we think about it and make headache specialists they lectures and not only lectures, generally discussions, including this one, more available to everyone. So what you're doing is very appreciated. And for our listeners, thank you so much for listening to these materials because we on this all together.
I love that. And I love what you said about uniformity and introducing some sort of consistency across migraine treatments. As a part of this project, as part of the UP-END Migraine project, we actually conducted a survey of people, healthcare providers, about how they are treating migraine. And one of the key findings from that was that it was really hard to identify patterns because everyone was kind of doing something a little different. And I'm wondering, what do you think the source of that variety in migraine treatment is? Why is there such discrepancies between how one provider is treating it versus how another is?
There is multiple things can play a role. One of those, and we addressing it with advocacy every way we can, is the barrier of, for example, this particular clinician has to work with insurance, which saying, okay, before you try this medication, you cannot try these other new ones. The one of the ways it got addressed that very recently, new updated recommendations from American Headache Society were published, which I really appreciate. It helps to move forward with newer medications right away, and maybe sometimes for clinicians even attach those recommendations to some prior authorization process. For me, it's definitely great resource. I also think that this variety comes with experience. Sometimes I speak to one clinician and they had amazing experience with this particular medication in the group of patients, and they love that they, for example, didn't have side effects and it's available and they will try it again. But in reality, we really need to be working on future of headache medicine, which is how do we find medication which is right medication for this particular patient. And we all trying to look at what are the symptoms there which can even now let us know, okay, so this person has, for example, vestibular migraine. And very recent publication was that some particular CGRP antibody worked well in vestibular migraine. So publications like that should be available and discussed and will address specific for this patient symptom. it would be great to have biomarker which says, okay, this is great medication for you. Because for now, people still sometimes have to try few medications until they find the right one. And then we have another issue that if they switch insurance, sometimes insurance make us start over with some medication which more on top of their line. And so we just went to DC with multiple advocacy group and patients organizations to explain to our policymakers why it's so important after all this hard work, when you do have medications which work for you, to keep using it, because it keeps people from emergency department. Prevention is so important to prevent this person from disability, to function in your family life, in your social life, at work. There is a lot of saving for all society when amazing groups of our people who live with migraine can function well and they don't need to go to emergency department. And emergency department is really appreciated that we have it. We actually working right now on new materials for our emergency department group, people who really doing amazing work. But with emergency department sounds and lights, I would love to keep everyone away when we can. And we really propose that all people who see in person with migraine, they would in the clinic start conversation of different layers. If you feel some signs that migraine attack coming, and many people do, that's what we would recommend, for example. And also it helps just to be more sure that you can function. So multiple studies done on people who live with chronic pain and migraine and other types of headache. And it's really stressful, to say the least, to not have something to stop this migraine attack. So these new medications really helpful and can be used early in the attack and really save us from utilizing emergency department, but also most importantly, avoid suffering and help function.
Yeah, I mean, so many wonderful things you said. I love how you started your answer with this discussion about the balance between that uniformity in migraine care, but also allowing for that customization for patients, because every patient is so different. I also appreciate that you talked about that there are so many other barriers outside of just what happens in the doctor's office that can inhibit migraine care. You know, insurance is such a big one. It's if you're in the right department, if you're in the emergency care department, there's going to be limited resources and limited time. And there's just so many other factors that go into it. And then at the end there, with your discussion on preventive treatment, yes, patients don't want to be in the emergency room. That is the last place we want to be. I'm more interested in preventing going to the emergency room, not necessarily preventing every migraine. So lots of good things. And I want to kind of shift the conversation towards that, the importance of preventive treatment. And you mentioned migraine overuse headache. And I'm wondering if you could just say a little bit more about the risks of medication overuse headache and what providers can do to help patients avoid something like that.
Yes, thank you. That's another great question. So medication overuse headache, especially in the past before our new modalities, was a huge issue. Some medications, such as older ones with barbiturates, could lead to medication overuse headache very fast. Even some publications showed that like 5+ days and person could already get to this medication overuse headache. With opioids, we really don't think that opioids are a good thing for people living with migraine. And I just want to say that we all would love to have different name for this medication overuse headache. When I discuss it in the clinic, I always make sure to explain that this name is our official name. It's from our international classification of headache disease. Another name people sometimes use, they call it rebound headache. And it's all kind of puts almost like negative emphasis on what person does. I love to explain that this is how we call it. This is what our brain does, but it doesn't mean that it's your fault because it's work with healthcare provider, with clinician, with your treatment team on creating better treatment so we don't have to use acute medications, especially all the modalities which lead to that. It's so much easier nowadays because now we have this, hopefully for big percentage of people, it works, the new medications, these GPANs, which they don't lead to medication overuse headache, we believe, and that would be another good thing to put in treatment plan together with neuromodulation devices. So neuromodulation devices always been very exciting for me because of beautiful, usually side effect profiles. Something with no extra chemicals in the body and potentially can be helpful, some of them for acute and preventive migraine management. Many people ask me for prevention. Well, we don't know if it's really work. I didn't feel anything right away, but all prevention takes a little bit longer than acute treatments. So we have a lot of nice devices, they FDA cleared, and they're very good for people who don't have pacemaker or other contraindication, which is usually metal, which not compatible with device, to try when possible. And again, it's different barriers to that, including that insurance only starts to do some approvals. I'm very lucky being in a situation when devices actually available for the patients in our Headache Center of Excellence, and I can advise it and we can try, and it's big difference with the past. I remember 10, 15 years ago, we would involve our colleagues in neurosurgery in some resistant cases when we needed to actually do procedure to try some pain modification device. And so now neuromodulation is so much gentle on the body because if we don't like it, we put it back in the box and we return it. So it's been much better. Hopefully it will be more accessible, and all headache neurologists, we are working on that together with our wonderful patients advocacy groups. So I just want to emphasize, if someone saying that I have those days which really unacceptable for me, I want to prevent them. Even if it's 4 days a month, we will reach out to something which may be different from person who has chronic migraine. So 4 days a month but disabling could be very significant. I really like how my mentor and teacher, Dr. Godsby, speaks about migraine days in the way that nobody gives you these days back at the end. So every day matters. So we love for our patients live without pain when we can help it. And things like nutraceuticals, for example, vitamin B2, coenzyme CoQ10, could be helpful when taken every day with guidance of clinicians. So everything has pluses and minuses, of course, but it does take time when we using something with less maybe side effect like vitamin B2, but we will not usually see effect in 3 days. It's probably more like 3 months. So that's variety.
As a patient, I can say that preventive treatment is sometimes the most frustrating part of my self-care routine because it doesn't feel like it's doing anything, but I know it is.
Yes, there is headache diary role. So I am really big believer that headache diary actually can give control back to us. So headache diary being a point of some discussion and multiple times. So one thing, we really don't want person to spend a lot of time diving in so deeply in the pain and writing about it for hours. But on the other hand, how do we figure out what worked, what didn't work, what to continue, what we should stop? Our brain trying to work in the way to forget pain and push forward so we can function better. So I am going for gold medal when I can. So maybe couple seconds a day, writing one number 0 to 10 on the pain scale. And if new something was started, we can mark it there with star or with any letter of the liking, or we can also put the acute medication. So maybe 2-3 seconds a day and different version of headache diary, all fine. But then when we look at that, we see trends and we can immediately say, oh, that was a great thing which we started 2 months ago. We know why we're feeling so much better. But also that a call for not just starting 10 things together, maybe start one and one preventive, one acute, see if we can at least sparse it little bit by few days. So if something had side effect, we don't want delayed treatments, but if something had side effect, we should be able to catch it. So maybe when available, if we start new medication, maybe put procedures at least week apart, a couple weeks apart. So then if procedure done something great, we know it. If procedure did nothing, we also will know that.
Gosh, it sounds like there's so much going on in the migraine treatment landscape right now. And for our audience that is maybe working in primary or emergency care, where you're seeing tons of different types of patients every day, you don't have a lot of time. When can you know that it's time to refer a patient to a specialist? At what point does that need to be part of the treatment journey?
I really believe that it should be pretty short journey. I believe that if we can help person who just started to have more migraine attacks and needed help, for example, in emergency department, maybe this person would benefit from 1-2 visits with headache specialist. And then they can continue this treatment plan for a long time when it works with their primary care, for example, and see us as needed if everything as planned. If person has difficult to treat headache disorder, migraine, we will see them more often, especially in the beginning, until we're in stable situation and modify. So I always say, if you think about headache specialist, and I hope that many people do, please refer to us. I think it's actually very good thing. There is no case that I would say that is not something that needed our help. I think all pain and all the symptoms, they need attention on the level of headache specialist when it's headache disorder. And then if this situation is such that we figure it out to extent possible during maybe 1-2 appointments, it's great. And people don't usually need to see us when they control. So headache medicine is very happy field, the way that, especially with newer treatments, our patients very often improve.
That's good news for me as a patient. Are there any new developments? You've talked about a few new things, but are there any specific new developments in migraine prevention that all healthcare providers should be aware of?
Yeah, we have more and more articles about how to work with medications we already have approved. And I think in the beginning, many people would be asking things like, can I use triptan in someone who is on preventive medications, which group of antidepressants, for example? And now we don't even have these questions. People saying it's fine, it's different types of receptors in general. So a lot of myths went away with time and education. We do like combinations of medications. So again, in the beginning, few years ago, many people were asking what will happen if someone on big molecule CGRP antibody, can I give this person Gepant? And now we know, yes, we don't see in general significant contraindication to that. And one of the great things about CGRP big molecules antibodies that they don't usually interact with any other medications. So that's been very important part. So they don't go through the liver or kidney in general, and they get disintegrated by the special cells, and they don't interact with other medications which people can be on. And then there is development of new medications. So new medications, one of new targets which we all really looking forward to see being in research is called PACAP. So it has very long name, same with CGRP. Those are both molecules circulating, and we learn how to address CGRP. And question is, can we learn how to address this PACAP, which plays also maybe bigger role in those premonitory symptoms, and maybe a little bit more concentrated around these ganglions which I mentioned, the SPG areas right on the both sides of the nose. So that's been very, very interesting. It's PACAP-targeted therapies. They still in development, and we really hope that it will work out because we do need more tools.
Yeah, this is so interesting to me. I see so much alignment between the questions that patients are asking and the questions that providers are asking, whether it comes to the interactions between medications. It's all part of just like building that more custom migraine treatment experience. And also with like new treatments, going back to that survey I mentioned earlier, we know that the patients that we surveyed, most of them are interested in new treatments. So it's wonderful here that there is that shared ground of like, we all want the same things. We all want migraine to be better. Just such an insightful conversation. Thank you so much for joining this interview, Dr. Riggins. And yeah, this has been such a wonderful conversation.
Thank you very much for having me.
In our next episode of Talking Head Pain for the Healthcare Professional, we'll be shifting our focus from prevention to acute treatment. We'll be talking with a nurse practitioner who frequently treats patients during migraine attacks, exploring the latest medication options and best practices for managing pain in clinical settings. That's it for this episode of Talking Head Pain for the Healthcare Professional. We hope this conversation provided valuable insights into the challenges of migraine diagnosis and how healthcare providers can play a key role in improving patient outcomes. If you enjoyed this episode, don't forget to subscribe to our podcast on Apple Podcasts, Spotify, or wherever you listen. And if you have a moment, leave us a rating or review. It'll help more people like you find us. If you have any thoughts, questions, or suggestions for us, we'd love to hear from you. Send us an email at podcasts@ghlf.org. Thanks for listening, and we'll see you next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.